What's up YouTube? I'm David Warren and welcome back to this week's video. If you're new to this channel, consider subscribing. My channel is all about being a nurse practitioner and being a CRNA student. I just finished my first year of CRNA school at the end of last year, end of December, and I'm currently a second year SRNA as of January 1 of this year. Currently February 9th at the date of recording of this video, so I'm a little over a month into my second year, and I'm about 4 to 6 weeks away from starting clinical rotations. And I want to share with you today some high fidelity simulation cases that we're going over in Simulation Lab. These are cases that our instructors are presenting us with, and we're really walking through our anesthesia plan and some emergencies that can arise intraoperatively and how to deal with those emergencies. And so I want to share some of those cases with you today. And you can comment below and let me know if this is something you're interested in me doing or continuing further, and I can certainly do that. But before we get started, I want to tell you about a really cool opportunity for those of you who may be sitting for your NCLEX before April, and that is a platform called Lecturio. So Lecturio is an online learning-based platform, and they're currently running a campaign to promote their NCLEX review software. And so the NCLEX review is really all-encompassing for everything you need to know to pass your NCLEX exam. If you didn't know, April 1, 2023, NCLEX is switching its testing style to something called Next Gen. And so this software will prepare you before that switch, before April. So if you're currently studying up and about to sit for your NCLEX before April, I would highly suggest you check this out. It's full of very high yield content to help you pass the NCLEX. There are videos and there are question banks to help you get a good review session in before you have to sit for the NCLEX. They're currently giving 20% off for this deal. I'm going to link the link below in the show notes. Take a look at that if you're interested in seeing what the review course produced by Lecturio is all about. So, with that being said, I want to dive right into what we're going to talk about today. So I have my paper here, and it's got everything we need to know about the case that we're going to talk about today. So I'm going to give you a little bit of an update on what's been going on over the past 3 months or so since I've been a little bit MIA. So the last time I talked to you, it was around November, I believe. I had just ran or was starting to run a half marathon, my 10th half marathon. I think I recorded a video maybe a few weeks before the race. Anyway, I ran the race, did well, set my PR actually. And since then, I have completed my first year of anesthesia school. And that by far has been the most grueling year that I have probably ever experienced in my life. And this is not really the video that I'm going to talk about that experience, but I am finished with didactic year of anesthesia school. I'm in a front-loaded program in Central California. And so I'm in my last didactic quarter. I'm in currently quarter 5 right now. So 4 quarters last year, first quarter now from January until the end of March. Starting April 1st, I'll be starting my clinical rotations, and I'm going to be somewhere in Nevada. I'm not going to tell you exactly where, but I'm going to be somewhere in Nevada for my first clinical rotation for 12 weeks. I'm super excited to get to the clinical arena and see what that's all about. But in our simulation lab, before we head off to clinical, we're doing what's called a crisis management course. And it's really about managing intraoperative emergencies. So bronchospasms, laryngospasms, all forms of hypoxemia and their causes, anaphylaxis, hypotension, difficult airways, all those things we're learning about how to manage intraoperatively and even during induction and emergence. And so this quarter we've been given a list of cases, and they are like 10 to 15 different cases, and they all have they're different patients, different ages, different weights, different procedures they're having. And then we will formulate an anesthetic plan, go forward with that plan, and then our instructor will throw different emergencies at us during the case, and we'll have to manage those appropriately. So I thought today I want to share with you what one of these cases looks like and what one of the anesthetic plans would be for this particular case. So I am going to be intermittently looking down so I can read some of this information to you. So this is our first case, and if you guys like this sort of thing, comment below and let me know what you think of it. If this is not something that's useful for you or it's not something you like, also comment below and let me know so I'll know not to do this anymore. But we're going to try one and just see how it goes, because it's going to help me study inadvertently for my exams coming up in this clinical course. So the first case we have is a 27-year-old male. He's 145 kilos, 165 centimeters tall, and he's coming in today to your OR for a lap chole. And His ASA, so his physical status, is going to be an ASA 3. He has no known allergies. His BMI is 54.7. Past medical history, he has morbid obesity, obviously by his 145 kilo status. He has regular cannabis use, edible and smoking. He has alcohol abuse, and he last drank last night. And he has no past surgical history. He doesn't take any home medications. His EKG showed a normal sinus rhythm. His labs were all normal apart from a mildly elevated AST and ALT. So, with that being said, what are your anesthetic considerations, or what's your anesthetic plan for this particular patient? And so I'm going to kind of walk you through kind of what we do as SRNAs and even as CRNAs, going through anesthetic plans and formulating what we're going to do for this particular patient. So the plan is really going to be broken down into separate sections. So the first is going to be airway management. We're going to come up with a plan as to how we're going to think about managing this patient's airway. And when it comes to airway, even as my background in emergency medicine, you always have to have a plan A, B, C, and D. You have to have multiple things lined up just in case something doesn't work out. You have other steps that you're going to go to in case plan A fails, in case plan B fails. So we'll hit that in a moment. Then we're going to talk about preoperative medication. So if we're going to give him any Versed or anything, anxiolysis type medications. And then we're going to talk about induction. So induction drugs, what's our plan for induction? What's our plan for maintenance? What's our plan for emergence and extubation? And so that really encompasses the anesthesia plan. So the first thing we're going to think about is going to see this patient in the preoperative area. And so we know that he has regular cannabis use and regular alcohol abuse. And so the first thing that you should be thinking of is this patient actively intoxicated? If this is an emergency case, there's a good chance he could be actively intoxicated. If this is an elective case, he's probably been told, remain NPO, don't eat or drink anything for 8 hours. And so whether it's an emergency case or a elective case, it's going to kind of depend on what you can consider as far as his aspiration risk and full stomach. However, don't always trust your patient. So when you go see this patient, you would always want to ask, when was the last time you had something to eat or drink, including alcohol? So if he had alcohol at 5 o'clock this morning and it's now 7 o'clock and he's acutely intoxicated, you always consider actively intoxicated people to be full stomachs. And so I want you to think about that before we jump to airway management. How's a full stomach going to change your airway management techniques? And you should be thinking about that now. So let's go say we went to talk to him and he says, I haven't anything to drink since yesterday or since last night. It's been maybe 12 hours. What's something you can consider doing to evaluate whether or not he has a full stomach? So you could consider a gastric ultrasound, and a gastric ultrasound is super easy to obtain. You put the probe right under the xiphoid process, and you look at the gastric antrum. And again, this is not the video to talk about gastric ultrasound, but you would evaluate his gastric antrum to see if there are contents in his stomach. If you get a view with him supine and you see no contents in the gastric antrum, it's what we call a target sign, just like a clamp down fist. You'll have him turn on his right lateral decubitus position, and then you'll get another view of the gastric antrum to see if there are contents moving back and forth. And you can switch him to his left lateral decubitus and do the same view to see if there are any contents shifting with the patient moving around. And so that will kind of clue you into whether or not you need to change your airway management plan. So let's say we did that, his gastric ultrasound is clear, nothing there. So our airway plan could be a non-RSI, just a regular intubation. And so I think I should probably explain a little bit the difference between an RSI and a non-RSI. So an RSI is a rapid sequence intubation, and that's the kind of procedure or induction technique that you're going to use for patients with full stomachs. And so anytime you have a trauma that is obviously emergent, you're going to consider that a full stomach. If you have a pregnant patient that you're doing a general anesthetic on, obviously that's going to be emergent. You're not going to do elective procedures on pregnant patients, and unless it is an emergency, then it's not elective. But after 20 weeks, about 18 to 20 weeks, you're going to consider pregnant patients full stomachs. And so the difference really between RSI and non-RSI is with your RSI medications, you're just going to slam your drugs one right after the other. So you'll give your fentanyl, propofol, sucks, wait 30 seconds or so for paralysis to set in, and then you're going to intubate, and you're not going to bag in between. So non-RSI, you know that they have an empty stomach. You can give your fentanyl, propofol, sucks, or rock, and you can ventilate in between waiting for paralysis to set in. If you're using sucks, maybe 30 seconds. You rock more like 45 to 90 seconds. And then you have your optimal intubating conditions and you can intubate. The real big difference is you're bagging one, you're not bagging the other. So for this particular patient, let's say that he has a clear stomach, nothing in there. So we can proceed with a non-RSI. So for airway management, he is, again, 145 kilos, and it's kind of hard to imagine this. I imagine this guy being kind of short and chunky with some redundant tissue in the neck region. But again, we don't have pictures of these patients, so it's kind of hard to say. But let's say you go in and you do your airway assessment. So your airway assessment is going to include the Mallampati score, your thyromental distance, looking inside the mouth, doing cervical flexion and extension, just seeing the mobility of the neck and getting a good idea of what's inside. And so I'm not going to go through all the airway assessment techniques, but you can look up Mallampati, and that's where you open your mouth and you're able to visualize what structures you see in the back, whether it's the tonsillar pillars, the uvula, the soft palate, the hard palate, and that gives you kind of an overall estimation of if this could be a difficult airway. However, obesity is not in itself a predictor of difficult airway. It certainly can be, but obesity in itself is, just because somebody's obese doesn't mean that they are going to have a difficult airway. So, however, with him being the weight that he is, it is prudent to consider that this might be a difficult airway. And so you want to have multiple different techniques lined up and ready to go. So for this particular patient, you can start with, there's really no wrong answer. You can start with direct laryngoscopy, which is using a Mack or a Miller blade to visualize with your eyes the vocal cords and then to put the tube between the vocal cords. You can also use video laryngoscopy, and you wouldn't be really faulted for that in somebody who's morbidly obese and who has the potential to be a difficult airway. Certainly wouldn't be at fault for that. You can consider an awake fiber optic intubation. In somebody that can open their mouth greater than 4 centimeters, where you can get the laryngoscope in and you can see adequately. An awake fiber optic might be a little bit overkill, but you would never be faulted for doing an awake fiber optic. That is really the safest way to manage a patient's airway. So let's say for this patient, we're going to plan for direct laryngoscopy. And so with direct laryngoscopy, again, we're going to use a Mack or a Miller blade. And so if you don't know what the difference between a Mack and a Miller is, a Mack blade is going to be the straight blade. It's going to be straight, and a Miller blade is going to be curved, C-shaped. Not C-shaped, but more like curve shaped. I don't want to say C because it's not that angulated, but it's definitely curved. Go Google Mack and Miller. You can see what the blades look like. And if you've worked in healthcare any amount of time, in critical care, you probably have seen a Mack and a Miller. There is difference, though. There's a difference between how they're used. So with a Miller blade, you're going to go into the oral cavity, and basically you're going to go all the way back to the hypopharynx, and you're going to use the tip of the blade to physically lift the epiglottis up. So if this is the epiglottis, this is your Miller blade, you're going to lift the epiglottis up like that. Now, with a Mack blade, you're not going to lift the epiglottis. You're actually going into the vallecula, which is behind the epiglottis, and you're going to use the tip of the Mack blade, which is curved, to push on the hyoepiglottic ligament, which is going to lift indirectly the epiglottis and give you that view that you're looking for. So that's how you could start, by doing either Mack or a Miller direct laryngoscopy. You could then move to videoscope. You could have a bougie, or what's called a gum elastic bougie, lined up, and that's a big long rod, and the end has a coude shape. And if you only have a view that allows you to see the epiglottis, you can slide that bougie just under the epiglottis, and then with a coude shape, with this little like ribbed area, you can fill the tracheal ribs as you're moving the bougie along. And then basically you thread the ET tube over the bougie and then down into the patient's mouth through the cords, and then you successfully intubate the patient. So those are the airway management techniques. Again, with this patient, we could start with direct laryngoscopy. We could have video available, have a bougie available, have several different blades available just in case. We would probably plan to use a 7 or a 7.5 ET tube cuffed, and that would be our plan for the patient's airway. And you would also want to have an oral airway that's appropriately sized for the patient available. So that way, after you give your induction drugs, especially somebody with a lot of redundant neck tissue, when they're supine, and you give the appropriate amount of medication to relax them, all of the upper airway musculature, so the tensor palatine, the genoglossus, all of that will kind of collapse, and could cause an airway obstruction. So you put in that oral airway to hold that open so you can effectively bag the patient. And again, you're not going to be bagging the patient if you're doing an RSI. If you're doing a non-RSI, then it's not really that big of a deal. You could also have an LMA, so a laryngeal mask airway, available just in case this is a difficult airway. You're not able to get it with direct. You're not able to get it with video. You reposition the patient, get them in the reverse Trendelenburg, you ramp them up. You still can't see the airway. Then it's appropriate to attempt either an intubating LMA or an LMA, so a laryngeal mask airway. It's a supraglottic airway. It's basically an oral airway that just sits right above the glottis, and you would ventilate that way. It's not considered a secure airway because you don't have something through the cords, but in a pinch, if you can't intubate and can't ventilate, then you can put the LMA in, see if you can seat the LMA just above the glottis, and you might be able to ventilate that way. And it would save the patient from having a crike. And so obviously the last step, you can't ventilate, you can't intubate, and you're not able to see anything to get the patient intubated, then you try an LMA, you can't seat the LMA, then the last step would be a surgical airway, a crike. And not something you really want to be doing, but a good skill to have in case you ever need it. Okay, so we're going to talk about preoperative medications now. So with this patient, recall he has cannabis use and regular alcohol use. And so you have to be thinking about what medications we're going to use. And you should have some alarms going off in your head. We're going to use a lot of medication for this guy because he has upregulated those GABA receptors that work with alcohol and cannabis and all the other depressants that this guy is taking. So he's going to require a lot of medication to get him in optimal intubating conditions. So we're definitely going to give him 5 of Versed, and that's going to help calm him down and hopefully take away some of the edge that the alcohol and the cannabis, or lack thereof, use over the past day or so would provide. And then we would consider giving him Decadron or dexamethasone 4 milligrams. So dexamethasone is a long-acting postoperative nausea vomiting agent. It takes several hours to work, and so you want to get that on board sooner. It's not something you're going to give immediately and see an immediate effect, but something that you would give and realize that it's going to take a little while to work, so get it on board sooner rather than later, because you don't want a 145 kilo person, when you're emerging them from anesthesia, to wake up and start vomiting. So give him the dexamethasone early. Okay, so induction drugs, you're going to use fentanyl. There are actually a variety of options, but for this particular patient, we could use fentanyl. And so fentanyl is going to be, for the induction dose, for the to blunt the sympathetic nervous system dose, is going to be around 1 microgram per kilogram. And so for him, we're going to say roughly 150 to 200 mics. Given that he abuses alcohol and cannabis, again, those receptors are going to be upregulated. It's going to take more medication to get him under. So I'm shooting probably more around the 200 mics of fentanyl. And so you're probably asking, what's the purpose of the fentanyl to give with intubation? And it's really to blunt the sympathetic nervous system. And so if you recall, the sympathetic nervous system is that fight or flight. And so really anytime you are messing with the airway and you're putting tubes through cords, it is extremely stimulating. And in fact, intubation, where you are doing direct laryngoscopy and putting an ET tube through somebody's vocal cords, is the most stimulating part of a surgical procedure. It's not actually the procedure itself, it's intubation. And so if you've noticed before, if patients aren't pre-medicated with something that will blunt that response, then they're going to get super hypertensive and super tachycardic just after intubation. And that's that sympathetic response. And we really want to try to avoid that. And ways you can do that would be fentanyl. Short-acting opioid agonist works at the mu receptor. And so you can give fentanyl 200 mics, 1 mic per kilo roughly. For normal, non-obese, non-drug abusing patients, 50 to 100 mics usually works just enough to kind of blunt that response. So when you do direct laryngoscopy, you put the tube through, you're not going to see that huge spike in blood pressure and huge spike in heart rate. And so you kind of control the patient's vital signs doing that. And that's more important for frail people with cardiovascular disease, something that you don't want them to have these wild swings in heart rate and blood pressure. But it's good to blunt the sympathetic response really in anybody. Other medications you can use lidocaine, and you can also use esmolol, which is a short-acting beta blocker. Our next medication we're going to give would be ketamine. And so again, this guy, with being 145 kilos, cannabis user, and an alcoholic, we're probably going to have to use more medication, which is why we're throwing the ketamine in. And so ketamine, we're doing 0.25 to 0.5 milligrams per kilogram. And so ketamine is an NMDA antagonist. and it causes a dissociative state. It's an analgesic. But the good thing is with ketamine is you're going to maintain your respiration, so it's not really going to knock out the respiratory drive. So ketamine is also a bronchodilator, so anybody that has asthma or COPD or things of that nature, ketamine is a good thing to give. Ketamine can also cause a lot of secretion, salivation, and so you can also follow that up with glycopyrrolate, which is going to be a muscarinic antagonist, and so you could block some of those muscarinic signs that you don't want, the excessive salivation, that sort of thing. And so that would be a good medication to follow it up with. And then we're going to use lidocaine. So 2% lidocaine, 140 milligrams. It's roughly 1 per kilo. The lidocaine serves a couple different functions. I don't know that there's really any evidence to support this first claim, but it's something that people say that whenever you give lidocaine through a peripheral vessel, it somewhat numbs up that vessel. So when you give propofol or etomidate or something that burns, it's not going to burn as bad. Again, that's more anecdotal. I don't know that that's really proven, but a lot of people do say that. So again, if there are studies that show that, I haven't been able to find any, please link them below. I'd love to see it. The other thing it does is it also blocks the sympathetic response, not to the degree that fentanyl will, but in addition to it will help blunt the sympathetic response. And then our induction medication of choice for this patient is going to be propofol. And I'll be honest with you, this is a bit of a sidetrack. Most RSIs or intubations that I've taken part in, I would say all actually, I've used either ketamine or etomidate. I've actually never used propofol as an induction medication. And so it's interesting to see now that anesthesia really just uses propofol unless there is some wild contraindication. You know, the patient's wildly hemodynamically unstable and you need to use something that's not going to toy with their vital signs quite as much, like an etomidate or a ketamine. Although ketamine still can, it's a direct myocardial depressant, so you'll still see some vital signs swing if they don't have an intact sympathetic nervous system. But propofol will give you more of that. And so there are a few different options. Even if the patient is wildly unstable, you can pre-treat them with like epi or ephedrine or phenylephrine, something to get their vital signs looking a little better before you induce them so you don't have that big of a swing. But for this patient, his vital signs are stable, so we're going to use propofol. So the induction dose of propofol is 1 to 2 milligrams per kilo. And so for this patient, we're going to opt for 250 milligrams of propofol. That's a lot of propofol. So for normal people, we usually say 1 mg per kg, 1.5. So for a like 70 kilo patient, really anywhere 70 to 100 milligrams is plenty, especially if you're giving fentanyl or ketamine or something of that nature. So I'll say routinely we don't give ketamine to like every patient. We're giving it to this guy because of his extensive abuse history to get him under adequately. If it were someone like myself or someone maybe like you who doesn't do drugs and doesn't excessively drink alcohol, fentanyl, propofol, and then your muscle relaxant would be probably sufficient enough to bring you under. But for this guy, 250 milligrams of propofol. So if you go heavy on the fentanyl, you can use less propofol, as we just said. But propofol is a direct GABA agonist, so it's going to increase chloride conductance into the cell, thereby hyperpolarizing the cell, preventing depolarization and preventing really any firing going on in the brain. It's going to prevent that hypnosis that you're looking for, sedation. It is also going to decrease preload, decrease afterload. It's a myocardial depressant. You're going to see some hypotension, that sort of thing. But you can always treat that. So unless they are wildly unstable, maybe pre-treat, like I said, with epi, ephedrine, phenylephrine, and then give your induction drugs. Or if their vital signs are stable, once you give 250 of propofol, they're probably going to get a little bit hypotensive. However, don't treat pre-induction hypotension unless really indicated. So if they have some sort of cardiac abnormality, aortic stenosis, that sort of thing, treat the pre-induction hypotension. But in a normal patient, you give 250 of propofol and their vital signs, they go like 80/60. Treat the hypotension with laryngoscopy. So putting the tube through the cords is going to bring their vital signs right back up because, again, that's a stimulating procedure. All right, now we're going to do muscle relaxants. So you have really two different choices, succinylcholine or rocuronium. And this is not an entire video on muscle relaxants, but I do feel like we need to talk a little bit about muscle relaxation. And so when we say muscle relaxants, we mean paralytics, not like Flexeril or Xanaflex or Robaxin, something like that. I think in like normal medical terms, when we say muscle relaxant, it's like, oh, an actual like muscle relaxant. But no, when we say muscle relaxant in anesthesia, it's paralytic. So succinylcholine, rocuronium are going to be really your two drugs of choice. There are other neuromuscular blockers out there, but we don't use those for induction because they take so long to onset. So Sux and Roc are really going to be your two biggest ones. And I want to talk a little bit about each. So succinylcholine is going to be the first one we'll talk about. And succinylcholine is a depolarizing neuromuscular blocker. So when you think of the neuromuscular junction of skeletal muscles, you have a motor end plate coming, or you have a motor nerve coming to the end plate on the skeletal muscle. And there you have nicotinic receptors. And at the end of the neuron, you have your vesicles holding acetylcholine. And so normal circumstances, the action potential will come down, will release calcium. Calcium will stimulate the acetylcholine release. Acetylcholine will bind to the motor end plate, opening the ion channels for the calcium to go into the skeletal muscle and to depolarize, causing actin and myosin to work, shortening the muscle, etc. You get the picture. And again, this is not a comprehensive video on the neuromuscular junction, but I feel like we have to cover a little bit of this to talk about muscle relaxant. So with succinylcholine, it's a depolarizing neuromuscular blocker. So succinylcholine is two acetylcholine molecules linked together by an ester bond. And so whenever you give succinylcholine, that molecule is going to go find that motor end plate, those nicotinic receptors on the muscle. It's going to bind to them, and it's going to depolarize, meaning it's going to open those ion channels, allowing everything to flood in. So calcium is going to flood in, and you're going to see what we call fasciculations. And so I've seen this myself before, and you probably have too. If you've given Sux, or if you've seen succinylcholine given, right after you give it, you get what's called fasciculations. And that's these like minor, you can see the muscle basically fasciculating all over the body. And that's the ion channels opening up, ions coming in. But under normal circumstances, if that were acetylcholine on there, then acetylcholine esterase will rapidly break down the acetylcholine molecule, closing the ion channels, and the muscle will go back to its resting state. However, with succinylcholine, it's two acetylcholine molecules, like we said, linked together. It stays on there, and succinylcholine is not broken down by acetylcholinesterase. It is broken down by pseudocholinesterase. And so pseudocholinesterase is located in the plasma. It's going to take significantly more time to break down the succinylcholine than it would the acetylcholine. And so that's how you get flaccid muscle paralysis, is those succinylcholine molecules stay locked on to that nicotinic receptor. Those ion channels are open and nothing can happen, because after the depolarization has happened and the muscle contraction has happened, then your flaccid paralysis sets in. And again, that's going to last for about 5 minutes. Onset within 30 seconds lasts about 5 to 7 minutes, depending on what kind of dose you give for the patient. And that's going to produce optimal intubating conditions. And then for rocuronium, it is a non-depolarizing neuromuscular blocker. And so think about that neuromuscular junction again. The rocuronium molecule will go to the nicotinic receptor on the motor end plate. It will bind there, and it will competitively block acetylcholine from getting on that receptor. So all these rocuronium molecules are lined up on those acetylcholine receptors, the nicotinic receptors, and acetylcholine can't get there, and so depolarization can't take place. And so with both drugs, you get paralysis just by different ways. One is depolarizing, and one is non-depolarizing. And so with the non-depolarizing, this is a very odd example, but think of it like either flumazenil or naloxone. And think about whenever you reverse somebody, if they've overdosed on heroin, you give them Narcan, naloxone, and the Narcan will go competitively bind to those opioid receptors, not allowing opioids to get on that receptor. And it's much the same for rocuronium. So rocuronium molecule will go bind to that nicotinic receptor, not allowing acetylcholine to get on there. And that's what causes the skeletal muscle paralysis. So we give our fentanyl, we give our ketamine, we give our lidocaine, we give our propofol, we give our Sux or Roc. That presents that onsets our intubating conditions, and then we can proceed with airway management. And so we can do direct laryngoscopy and then adjust our plan accordingly, whether our first pass is successful or not. And after that, we're going to turn the patient on to vent mode, so from bag mode to vent mode on the anesthesia machine, and we're going to set our vent settings. So the vent settings are quite different than what you're used to in the ICU, very basic. So we're going to use 6 to 8 mLs per kilo of ideal body weight for tidal volume. So that's going to average out to be about 400 to 450 for this patient. Volume control, rate of 14, a PEEP of 5. So most patients are going to get PEEP of 5 unless you have some sort of obstructive lung pathology, so emphysema, COPD, blebs, things like that, then you really don't want to use PEEP for those patients. And then after that, we're going to enter our maintenance phase. And so the maintenance phase is kind of the not the relaxation phase, but the phase of where you're not quite as busy during an anesthetic. And so you're still vigilant, you're still paying attention to what's going on, but you're not doing all these procedures and pushing medications like you would during induction or during emergence. And so the maintenance phase, we're going to use gas anesthesia. So our volatile anesthetics, there's sevoflurane, isoflurane, and desflurane. Really, sevoflurane and isoflurane are the most common ones. And so it's not a pharmacology course, but for this patient, we're going to use sevoflurane, and our dosing is going to be around 1 to 1.5 MAC. And so MAC is minimum alveolar concentration, and 1 MAC is where 50% of the population don't respond to a surgical stimulus. And so typically, you're going to have to give a little more than a MAC, and so 1 to 1.5 MAC is really average. And then we will redose our paralytics as necessary based on what the surgery requires. So for this abdominal surgery, laparoscopic, we'll definitely need to redose our paralytic if we need to. We can check twitches to do that. And then after that, the surgery will get started. So for this particular surgery, a lap chole, the most dangerous part of this procedure is going to be initial abdominal insufflation. So when they put either the trocar in or the varus needle in to initially insufflate the abdomen, and they use CO2 gas to do that, and CO2 is used because it's so soluble and because it's not flammable. And so CO2 is really the desirable agent to produce that abdominal insufflation. However, initial insufflation, you put the varus needle in or the trocar, there's a chance you could hit a vessel and just give a blast of CO2 in there and cause a venous air embolism. Abdominal insufflation also causes usually a sympathetic response, so significant hypertension, tachycardia. Treat that with a little bit of fentanyl. If it causes the opposite response, significant bradycardia, then you want to tell the surgeon stops insufflation and probably give some either glyco or atropine, depending on what the heart rate is. So those are some considerations for this case. And then after the surgery is done, we'll move into our emergence and extubation. For this patient, we're going to probably plan to do an awake extubation just because he's so large, and we don't really know when his last drink was. Again, we determined maybe it was last night. We really still don't know. Given his obesity, it's probably reasonable to do an awake extubation on this patient. You can do a deep extubation. A deep extubation is where they are still under about 1.5 MAC of gas, and then you pull the tube deep and you have them breathing spontaneously and they slowly wake up already extubated. For this patient, we'll do an awake extubation. And Precedex is probably going to be one of the best things that we can do to help our patients wake up smoothly. So Precedex is an alpha-2 agonist, and alpha-2 agonist is a super interesting mechanism of action. It really prevents presynaptic release of norepinephrine. It works in the spinal cord for analgesia, and it works in the locus ceruleus to provide sedation. So look up Precedex if you're not sure of the mechanism of action of that. Again, not the video for pharmacology, but I feel like, again, with anesthesia, there's so much pharmacology, we have to hit on a little bit of it. But doing Precedex, an initial bolus of about 140 mics will help give us a smoother wake up than if we just cut the gas and try to pull the tube and wake the guy up. We're going to turn our gas off about 15 minutes or so, 20 minutes before the procedure is completely done. When we turn our gas off, we're going to give bumps of propofol, so like 20 to 30 to 40 milligram pushes. So like landing a plane, you don't want to just turn it off and boom, down you go. You turn the gas off and you slowly wean yourself down with little boluses of propofol. And so that's going to help the patient wake up smoothly. For muscle relaxant reversal, it's going to depend on our twitch response. So if we have at least one twitch back, we can use neostigmine and glycopyrrolate. So neostigmine is going to be an anticholinesterase. It's going to inhibit acetylcholinesterase from breaking down acetylcholine, and so thereby making acetylcholine more available. And then we'll give glycopyrrolate to counteract the muscarinic side effects that come with acetylcholine overload. So bradycardia, salivation, defecation, all of those things that we don't want to happen at the muscarinic sites. So muscarinic being autonomic nervous system, nicotinic being skeletal muscle. So give glyco first to let that start working. It takes about 5 minutes to onset, then give neostigmine to reverse the paralysis. You can also use a medication called Sugamidex. So Sugamidex is a newer medication within the past few years. It's a cyclodextrin molecule, and it basically encompasses the rocuronium molecule or the non-depolarizing molecule and eliminates it. And so you can give Sugamidex. You don't have to worry about the muscarinic side effects or anything like that. And then at some point we'll work in our Zofran for postoperative nausea and vomiting. Whenever the patient starts breathing, we can see the curare clefs on the end tidal waveform. We'll switch over to pressure support at like 10/5, and we'll just wait for the patient to start pulling 300 to 400 tidal volumes. And we'll slowly work them down from a pressure support of 10/5 all the way down to 5/5, then ultimately into bag mode. And once the patient is pulling adequate tidal volumes, good respiratory rate, to initially do that though, we have to let their CO2 build up, the hypercapnic drive to breathe. And so we will initially drop the rate from like 12 all the way down to 5, let their CO2 build up into the mid 50s, and then the patient will start breathing, and then they will pull their own tidal volume, and that's when we start working in the pressure support all the way down to 5/5. And then into bag mode, wait for them to again start pulling 300 to 400 tidal volumes, normal rate, and then we will plan to turn our flows all the way up, cut the gas, or if we're doing a wake extubation, we've already cut the gas. If we're doing a deep extubation, we would cut the gas now, and then pull the ET tube, put the mask on the patient, and then assist with respirations as necessary. We would also probably have an oral airway worked in at this point, suction really well, and then ultimately we're going to pull the oral airway out, put a non-rebreather on the patient, and then off to PACU they go. So that's a little bit of an overview on what one of the patients that we would go through in our simulation lab looks like in our anesthetic plans. And I'll do some subsequent videos over this, but really this quarter has been dealing with, for me worrying about, but for our professor learning to deal with anesthesia emergencies. So bronchospasm, laryngospasm, hypoxemia, difficult airway, that sort of thing. So in subsequent videos, I really want to go over and share with you how we treat those different emergencies. But for now, I really wanted to give you a sample case to let you see kind of what we do and kind of how an anesthetic works. Again, not all encompassing, but you kind of get the idea. If this is something that you like, comment below and let me know. I can certainly do more of these. They're a little time consuming, but I think it's interesting to walk through these cases because it really helps me study and it gives you an overview of what anesthesia is actually like. So comment below with your questions. If you have any questions about the anesthetic or any plan, anything you would change, comment below. I'd love to hear it. Thanks for watching, and I will see you next time.